Okay.
Yes, thank you.
So a lot of times depression first manifests in places other than my office. And so actually probably the number one way kids get referred to me is usually by their primary care provider or often by their therapist, because sometimes that's where people start. And we've made a lot of gains in getting people to understand and realize the seriousness of depression, but getting treated for depression has notoriously been stigmatizing for adults, but also sometimes quite stigmatizing for children, sort of a belief that kids really cannot be depressed, or they can just sort of pull right out of it, or it's always situational. And unfortunately, that's not the case. Sometimes kids really do suffer significantly. And it's really important that we acknowledge that. So, depression tends to be something sometimes people suffer with in silence. And when we talk about how it presents in adolescence, sometimes adolescents notoriously can rebound in their environment and not show all their suffering in certain situations. And so it's really important we don't miss this, because of course, untreated depression is a notoriously high risk for suicide. And when you think about young people, if you think about adolescence into young adulthood, suicide is the number two cause of all deaths in this population. The first is accidents, and the third is often exposure to violence, which often has a lot of mental health overlap. So this is one of the clear reasons people's lives end early, and often it starts quite early. So we don't want to miss it, and we want to make sure we recognize it and offer treatments. It can occur before puberty. Rates are about 1 to 3%. From some of our other lectures, we've talked about things that can increase someone's risk of having depression. Certainly children that are in high conflict environments that might have elevated cortisol. And there have been reports, as we talked about, with kids that have been exposed in utero to substances may actually have higher rates than the general population before puberty. But hormones appear to be a big role in most depression. And so we really begin seeing a huge increase after puberty in kids and adolescents. And so these rates can be quite large, from around 5% up to 20%, or 1 in 5, depending on what study you look at. But almost all adults that suffer with depression, not all, but upwards of 80% of adults will actually report that they could clearly identify their depression starting when they were adolescents. In this ratio sort of thing, this is the male to female ratio. It tends to be quite equal before puberty, and then after puberty, it appears to affect females more so than males at a 2-to-1 ratio. And some of this is a belief that maybe testosterone helps sort of mood a little bit more. And this is the really shocking number, that many of our kids suffering don't actually ever receive treatment. This is a little bit of an old statistic, probably from about 7 or 8 years ago. I did not have a more current statistic for you. I'm hoping with gains that we've made in access to care and more treatment that this number is going up. Going down, and that more kids are getting treatment, but I still think it's a lot of times missed. In fact, probably the most common way I encounter kids with depression, unfortunately, a large chunk of them is after their first overdose or suicide attempt in the hospital. We'd like to catch them sooner. So there's certainly lots of risks. Certainly this is illness that runs in families. So having a parent or two parents with depression or mood disorders can really increase the risk. All these other sort of problems, academic problems, family stressors, chronic illness, again, all states that chronically cause stress, rise in cortisol hormones that can lead to higher risk of depression. Here are the criteria for major depression. I think many of you know this already. So it's just 2 weeks of profound 5 of these symptoms. And the key, again, is that it causes distress and significant interference as the official. And these criteria are actually not different from adults. These are actually the same criteria as for adults, may present a little bit differently, but the actual criteria are not different. There is another condition that is now called persistent depressive disorder, used to be called dysthymia, that does have some differences from the adults. Dysthymic and persistent depressive disorders are sort of considered like a low-grade depressive symptoms that usually aren't as severe, may have better functioning, but people continue to be persistently struggling and down. In adults, the cutoff is 2 years. In children, it's 1 year of persistent low mood symptoms. It's pretty rare for a persistent depressive disorder to have acute suicidality. Usually if acute suicidality is present, you're looking more at major depressive disorder. It's also, though, important to realize that in young people, it may be hard for them to walk in and say, my self-esteem is low, or it may be hard to say, I'm having trouble concentrating. And you often hear vague language. So lots of times kids are coming in with depression and they may be really facing problems following rules, or they're feeling inadequate or more irritable. In fact, the word irritable is a very vague word in psychiatry. And most of the time when you really do an in-depth screening, that persistent irritability more likely is depression than anything else. But you have to kind of spend some time teasing that out. So why do we think about treating it? Generally speaking, a depressive episode lasts about 7 to 9 months, and most of those episodes will get better on their own. The problem is it may take 2 years to recover without treatment, which is a really long time to suffer. And with young people, if you're suffering and you fall off your developmental ladder or you struggle at school, you're setting yourself up for falling behind developmentally too, which may lend itself to worse outcomes. Dysthymic episodes may average 4 years, and the problem is that there's often high risks of relapse even after it. And like most things in child and adolescent psychiatry, it's often messy. They don't just come with one problem or depression. There's often other problems going on as well. There's risk for substance use, anxiety disorders, abuse, disruptive behaviors, eating disorders, learning disorders, and just about everything else. Sometimes depression comes second, but sometimes depression comes first and is unidentified and the driver of some of these things. So again, we treat it and look at it because we know that kids struggle, and if we don't treat them, we see increased risks of suicide, but we also see them struggle at school, struggle in relationships and families, and chronic ongoing childhood depression may also be more likely to eventually evolve into bipolar disorder. And so the challenge is that the average age to begin experiencing a manic episode is often less than depressive episodes. So a child may present with full-blown depression and never witnessed true mania, and you will never know at that first visit if they're going to go on to declare themselves. So we have to watch for the development of that in these kids. But these are sort of 5 warning signs that occur in the depressive episode that are things to just be mindful of that may suggest that the child could convert to bipolar disorder later on. They still have to develop mania and meet criteria for that, but these may be things that have occurred before that happens that just tell you that you need to keep a little closer eye on this child and they have a higher risk of converting their depressive episode down the road. So one is activation from SSRIs, which are the main medicines we use to treat this with, and we'll talk about that. So you need to be mindful. Activation often means agitation, irritability, or restlessness that comes from the medicine being started. Strong family history of bipolar disorder, especially in a parent or other first-degree relatives, so that would be a sibling or a parent, really may increase the risk. If they present with psychotic symptoms while they're depressed, like they hear or see things, or they have sometimes kids will get intrusive kind of like visual images of like the devil, or persistent negative thoughts that sometimes mimic sort of a paranoid delusion. Those would increase the risk. Lots of times when kids are depressed, they can signal triggers or things that caused it. But children that seem to be normal functioning that crash suddenly into depression, this may be normal functioning, and then really in the matter of a few days being so depressed they can barely get out of bed, that does not seem triggered, may also harbor a higher risk of bipolar disorder. And then children that present really slowed down in their depression, we call that psychomotor slowing, meaning they're thinking really slowly, they're moving really slowly, or kids complain of almost like a heavy leaden paralysis, meaning their arms and limbs are really, really heavy, and they don't feel like they're moving or thinking as fast, may also be a risk factor. So these are the things that are often hard in kids because they don't often walk in and say, I'm depressed, sometimes like adults do. I think more kids are able to say that word because there's been some pushes to educate people more about depression, but oftentimes that's just not a word the child would use. They may not even say they're sad, but they often come with very general language. Sometimes it's just lots of complaints. Tummy aches, headaches, body aches, things that have persisted and no one can kind of find a cause, but they feel just bad. Sometimes kids say they're fine and they're happy, but when you look at them, they just look miserable. They're sad, they're flat, and everyone thinks that they just look unhappy. Most kids report feeling irritable, and that is often things like, everybody gets on my nerves. I just wish people would leave me alone. I'm bothered by everything. And they feel so negative and they become argumentative, they pick fights, and people kind of think of them as more antagonistic or negative, but they can't really come out and say they're sad. The tricky part is their mood can still be really reactive. So they can respond to environmental things that temporarily boost their mood. And this often is because they're hanging out with their friends or they go to a party. And what you'll often see is kids that report they feel down most days, but their parents will say, well, they seem to go out and hang out with their friends and they look great. And they come home and they don't want to do anything. And it's very hard for them to realize that that actually is pretty typical in kids, that positive events may cause them to temporarily come out. Kids often don't report anhedonia, they just stop doing things. I'll have kids that have quit basketball or quit sports, and they won't tell you that they just didn't want to do it anymore. They tend to make excuses. It was stupid, the people were dumb. And my favorite is when you ask a child about things, their feelings, and everything is, I don't know, I don't know, I don't know. Often they really don't know. And that's really getting back to this idea of anhedonia and not caring. And you see them withdraw from things that they used to do. Often there are changes in their weight or eating. And as I said, sometimes kids can really have motor slowing or even physical agitation. Some kids get real restless when they're depressed and irritable, and they pace or they tantrum more. It's also really hard for kids to talk about self-esteem unless they're in families where that's a common thing to talk about. And it's really hard sometimes to tease out that feeling of feeling like inferior or failure or self-critical. And they don't often like directly say that. And I usually approach it like with them is, you know, tell me how you're really feeling about who you are right now. You know, are there days that you kind of struggle to like yourself like maybe you used to? And that can really help kind of tease out this worthlessness or inadequacy thing. And some kids are real reluctant to admit that, but you have to kind of figure out how to put it in their words a little bit. And sometimes kids are presenting with drops in schoolwork because they can't concentrate and focus, or they may actually be starting to have suicidal thoughts, but may just be thinking or ruminating about death. And you'll see some kids get really stuck on morbid themes in music that talks about death or dying that can kind of go along with their mood state. So as you're trying to figure this out, you really want to to try to get as much information as you can from parents, school, and watch how their affect responds. One of the most important things sometimes during an assessment is I try to get the kid talking about something they like or something I knew they used to like. And if someone's really depressed, they may even have a hard time like smiling about things that you know they like. They really don't have that reactive mood you would think. I also think it's really helpful to use a rating scale. Sometimes people will answer things more honestly on a rating scale than directly too. And I'm gonna have well, let me go over this part first, and then I'll show you. I'm gonna have her send out a rating scale to you all that we use often in our pediatrician clinics. It's a little different than some of the ones out there to screen for depression, but there are other medical things you want to consider. Certainly kids that have chronic medical conditions, if those medical conditions are not well treated, that may be contributing. Things like elevated blood sugar, kidney disease, all of that may be a problem. But lots of times kids present with no other medical history, and you want to think about acute things. So we often check thyroid hormones. Simple vitamin levels like vitamin D, folate, and ferritin can really be off, and this can impact their energy and mood. We're really notorious in West Virginia to have low vitamin D levels because we don't get very much sun, and vitamin D can often be very pervasively low and contributing. And it's not that this may be contributing completely to depressive symptoms, but if these vitamin deficiencies are really present, medicine often doesn't work very well to correct it if you don't correct the vitamin deficiency alongside it. You know, we want to make sure we're not missing malnutrition or eating disorders. When people lose weight or significantly underweight, they present as looking very depressed too. And some of that is because your brain actually does not have any of the energy it needs to think or do things. People that are severely malnutritioned, underweight, or suffering from advanced eating disorders may appear depressed when really it's a result of just not having the fuel for your brain to work. And also, don't forget to ask people about substance use. I have a lot of kids that are struggling. They may have even tried treatment for depression. I find out they're using alcohol and marijuana pretty heavily, and those are depressants that will keep their mood down, may be part of it. So I'm going to skip over this, but there's several rating scales people use. This is one I like because it's really easy to screen for, and it's a little bit more in depth than some of the PHQ-9s that are in use, but this is called the Columbia Disc Screen, and I'm going to pull that up real quickly here for you if I don't lose my other screen. Did you share this already, or?
Yeah, Dr. Sutter, I have it on my end if you'd like me to pull it that scale.
No, I have it. This will be sent to you guys. Let me just reshare here. Can you guys see that? This is the typical screen for, there's one for the teenager themselves and there's one for the parent themselves. And you just see there's a little bit more in depth. I think the language on this is a little bit better in terms of getting at more of a way an adolescent might talk or think. And it's just a yes/no question, but it's a little bit more in depth, all the way down of 22 questions. And it tells you right here at the bottom how to score it. And it kind of tells you how likely or unlikely that we see these things in teenagers. There's also a parent version that kind of gets at both some of the physical things, but also some of the more neurovegetative symptoms that you might not see. So this may be an alternative. And often in a primary care setting, one of the best ways to do it is as the nurse sort of checks them into the clinic and they're waiting for the doctor to come in, the kids and the family may be filling out the rating scale as they wait for them so that they can hand it to you when you walk in. A lot of the referrals I get, they screen positive in the pediatrician's clinic, and I see them afterwards. So let me get rid of this and go back to the PowerPoint here. Okay. I think probably at some point just talking about suicidality and maybe its own lecture would be helpful, but because I know that's a complicated discussion, but it is important to ask directly if kids have thoughts about suicide, either now or when they have. And often if I get an answer, yes, I'll say, how close did you get to acting on that? Or had you acted on it, and really trying to get specifics. And it's kind of important that you use the word suicide or kill yourself. Kids don't interpret, do you have safety concerns or do you have negative thoughts? They're not going to know what you mean by that. So you really do have to ask, have you had thoughts about killing yourself or ending your life? Or have you had suicidal thoughts, pretty directly to get an honest answer. The good news is, if you have a strong supportive family, having suicidal thoughts doesn't necessarily mean you need an immediate admission, but it may mean that you need to have an open conversation about safety with the family. But if they say yes, you have to ask if they're having thoughts about what they would do, and you need to ask, have you thought about a plan, or how likely do you think you'd want to act on those thoughts to know the true risk that they may be exhibiting at that point in time. It's important to remember, if suicidality occurs in the context of clear major depression, that getting treatment for depression might be one of the best ways we can modify that risk, and I'll talk about that a little bit later. You also want to kind of know what the current stressors may be. If a big stressor is bullying at school, you may need to have school interventions alongside additional treatments. So most pediatric depression is treated in the community by family care providers and pediatricians. But if you're struggling, here might be a sign that you need a referral to other help. Certainly if a patient has continued to be depressed, even with standard treatment, it might be time to get a second opinion or think about a second or third line treatment option, which is often what happens with referrals to me. I'll see kids after they've failed 1 or 2 medicines or psychotherapy to look for other options. Are there other things going on? Is there substance use, ADHD, anxiety, or something that's getting in the way? Profound or declining functional impairment. Sometimes if things are really stressful in the family, that child may not get better until the family or the parent gets better. And sometimes if I have really overwhelmed parents, sometimes maybe helping the parent access and get care might be also important. If you aren't sure about the diagnosis, the patient's very guarded or even suspicious, and you suspect they have hallucinations or psychotic symptoms, would be a reason. If you have a high likelihood or high risk at that time of actually having a suicidal attempt, you may want to seek a second opinion. If you can't trust your family, the family is having a really hard time supervising this child or not watching this child, or the family won't lock up medicines, and the kid has access to firearms on the home, and it's hard to engage the family, you may need a higher level of care. And some people just really aren't comfortable prescribing. So as we make the diagnosis, we really have to involve parents. There's a big psychoeducation that plays a role. Kids do better and families do better if you talk about how depression might mimic their behaviors, and certainly trying to get the family to see it as coming from depression, if that's the case, instead of just viewing it as a behavior problem for which this kid needs more punishment, which will only add to the negativity and depressive symptoms, is really important. And depression really truly is a medical illness. We can scan your brain and tell you that your brain isn't functioning the way it used to, and that treatment is indicated. Can be a more helpful way to think about this than just a behavior problem that is going on. And if you make the decision to treat with medicine, that's going to involve lots of conversations with the parents in terms of what to look for in terms of side effects and improvements. We often need the help of parents too to help kids take medicine. I am well over middle-aged, I think, at this point in my life, and it is still hard to take medicine every day. And I think it's hard to assume, if we're honest, that a 15, 16, 13-year-old kid is going to easily get in the habit of taking medicine every day. Some kids don't even know how to swallow pills. And so, although I know parents often wish that the kids will just be responsible and do it themselves, that's not honest even for most of us adults. So the more people we can engage in helping build medicine or treatment into their schedule, the better. The same thing for therapy. Like, why is it important to go every week? There's a lot of misunderstandings about that. Money or the cost of treatment could be a barrier, and you want to make sure that people are honest with you if they're worried about that, because there may be options around that. And one of the biggest roles, and even if the parent denies treatment, either therapy or medicine, having that parent engage and be supportive with the kid is one of the most helpful things you can do. And most kids that die by suicide reach for something impulsively. They feel distressed and overwhelmed in the moment, so they reach for what's in the cabinet or the gun that's there because they don't pause to think about another way. So building time also builds some hope. So if you can just at a minimum get a parent to agree to lock up all medicines in the house, especially the over-the-counter medicines, because Tylenol and ibuprofen are actually some of the most lethal ways kids die, easily accessible things. If they will lock them up and ensure there are no access to firearms, and kids often know where the guns are, even if the parents don't think they do. So you really have to talk about gun safes, removing the bullets, making sure they don't need the combination, giving the weapons to a neighbor until the child recovers. That may be the one single thing you can do to save a child's life or an attempt. And so, again, I always say that even if the child hasn't specifically had suicidal thoughts, it's important we acknowledge that if they happen, it's something we want to be able to talk about. So we do have some good treatment studies with kids, and so I'm going to quickly review for you the practice guidelines for this, and so that you understand about the role of medicine, what we know, what we don't know, and what's on label and off label. And you really want to make sure, again, parents are involved in helping you treat side effects. So if you see, and there is a lot of psychosocial stressors going on, you really ought to also think about suggesting psychotherapy, because part of the recovery from depression is not just feeling better, but it's learning to regain skills. And for kids, they need skills to move forward, to manage their mood, or even talk about their mood. And psychotherapy is such a critical part of that. So really, every kid with depression, whether it's mild or severe, would probably benefit from a recommendation for therapy if they can get it. We also know that therapy is the #1 way to reduce suicidality, even in kids on medicine, because they feel supported, and it's a place where they have that one-to-one adult attention that they may not get in other areas to establish a sense of hope and moving forward. So really, therapy should be something all kids should be offered. Not all kids or families want it or can do it, but it's really important for kids that are struggling with more core coping deficits. Medicines may be indicated in certain cases. Medicines are much more indicated for moderate into severe forms of depression. If you just have mild depression, we usually recommend starting with therapy. But in kids with significant symptoms, the moderate to severe group, and these are often kids with suicidality, or if they're too depressed, some kids are too depressed to participate in therapy. A lot of the data suggests that the combination of therapy with medicines may be far more helpful and has better outcomes. We even sometimes have to think about things like ECT, electric convulsive therapy, for kids that are really, really ill. And these may be kids that are so ill they have catatonia, or they stop eating, they're so depressed. Again, rare, but something that does have some evidence base. When we talk about medicines, the trial of a good dose is about 4 to 6 weeks. So we have to make sure people realize that there's some patience with this. People do not feel better tomorrow, and recovering is a process. And we have to try to find some ways to behaviorally activate people. So things like exercise and good sleep hygiene also really help mood. And so sometimes just getting somebody to move, even though it's the last thing they want to do, may also help. Sometimes depression has caused such interpersonal difficulties as well. Kids need a lot of sort of guidance on how to build their social skills and even just communicate about their feeling states. We have 2 major medication studies that are worth knowing about, that we often lead to which medicines we pick. This study was called the TAD study, which was a very large study of adolescent depression. And it used Prozac or fluoxetine combined with CBT. It had 4 arms. It had a medicine-only arm, a therapy-only arm, medicine and therapy, and then it had a placebo arm. And about 60% of all kids got better. And the recovery rates seem to do better with both therapy and medicine. The medicine alone seemed to be the kids that endorse more suicidal thoughts, which I'll talk about a little bit later. And the therapy group seemed to be protective against suicidality. The combination treatment of medicine and therapy also seemed to have better functioning overall. But the medicine part seemed to be much more helpful for like physical functioning, like moving and focusing and concentrating and some of the physical symptoms, especially for the kids that had trouble getting out of bed or moving or going to school. When we talk about medicine, we'll talk about SSRI as being first line, but sometimes kids have had adequate trials of an SSRI medicine and they still don't respond. This study, the Tordia study, was kind of the, what do you do if your first medicine trial fails? So that was resistant depression, and that meant a legitimate trial at the right dose for 6 weeks of an antidepressant, and they still didn't get better. So in this group, they took the kids and they either switched them to another SSRI, tried venlafaxine, which is an SNRI with norepinephrine. They may have tried a different SSRI and added CBT, or they tried venlafaxine and added therapy. And what they found is that switching between medicines, switching to venlafaxine or switching SSRIs, did get both groups better, but maybe switching to venlafaxine was a little bit more side effect heavy in terms of medicine. And that, again, that adding CBT was also very helpful at getting some of the residual symptoms better, even after an SSRI if they had not already been enrolled. The standard response rate to medicine for their first trial of medicine is about 60%. So there's going to be a large chunk of kids that don't respond to medicine alone. And so we really cannot think about medicines as the only treatment we can offer people. Even if it's not traditional psychotherapy, but finding ways to build support either through group therapy at school. Some kids will even want to do self-paced work if they don't want to miss school, and getting them to legitimate resources are always really helpful. I'm going to skip that. When we talk about specific medicines, and I'll go through this part quickly so we can spend some time on discussion, we most always, if we don't have another reason why, pick fluoxetine or escitalopram first. And the reason we do that is because those are the ones that have FDA approval. And if you've heard me talk before, you've heard me say FDA approval does not mean no evidence. And we have medicine with other evidence, but these are the only ones that carry that FDA approval. So we tend to use those more. The fluoxetine is approved through 8 to 17, and the escitalopram is 12 and up. Okay, I'm going to show you a dose table here, but the goal is to get the medicine up to the right dose that they can tolerate, and that you wait for 4 to 6 weeks to see if it gets better. If you don't see improvements on any dose after 4 weeks, you want to either increase the medicine to the target dose, or it may be time to consider an alternative. We do suggest close monitoring for kids. Initially, when the black box warning about SSRIs, which I'll talk about in a minute, came out, they suggest that kids be seen every single week when they get started on medicine. This turned out to be pretty unrealistic. Doctors could not get kids in their office every single week to check in. This is also a big role that therapy may play in helping people. But the new approach is to think about how severe the patient is, what level of functioning they're had, and make the best case scenario. However, I almost always see kids within 4 to 6 weeks after every dose change and make sure they know how to reach me in between. Also, I think therapists should know if you see a major change and you know your patient started a medicine, the prescribers always want to know if you see or are concerned about a side effect, because we need to support these kids every way we can. I do not advise putting someone on a medicine and telling them to come back in 6 months. That seems to not work. So it is a high burden monitoring that occurs with these kids. If they have success with the medicine, you usually want them to stay on it anywhere from 6 and to ideally 12 months. It's really hard for kids to buy into the idea of taking a medicine forever, so we never say forever. We just say that until they feel better. And then once they feel better, I try to keep them on it feeling better at 6 to 12 months because they have a higher or a lower rate of relapse and higher chance of success in being able to come off that medicine if they don't pull it off too soon. And I often use the analogy that the medicine for treating depression is kind of like if you're a marathon runner and you twist your ankle and it's all blown up and it hurts and you have to wrap it and ice it. It's going to hurt and be painful for a while, but it's going to get better. And the medicine might help it get better, but your ankle isn't perfect yet. And you're not going to go back out and run a marathon. Your ankle's going to keep healing for weeks to years, and you're going to have to train it again. And that's kind of what the medicine does. It helps protect your brain and let it keep healing up for that full 12 months so that you have a better chance of coming off of it and not needing to go back on it. Because kids stopping their medicine too soon is one of the highest reasons that we see relapse and return of symptoms in kids. If a child has had psychotic symptoms, multiple episodes of depression, especially more than 3 episodes of depression, or we've tried to change it in the past, those kids often need to stay on it longer. We don't have great long-term studies with these medicines, but we certainly have had kids and adults on medications for years. And we don't know of any terrible, scary, terrible side effects from staying on these medicines. There was some data that maybe staying long-term on an SSRI might impair bone functioning a little bit. So I usually encourage kids that have to stay on it beyond 12 months to make sure they're taking a calcium with vitamin D supplement or drinking enough milk and dairy. But most of the time, the risks of that depression and suicidality are far going to outweigh side effects or any dangers we know of these long-term use of these medicines. So again, if the patient has had resistant depression, we usually try another SSRI or we try venlafaxine next. One of the things I would urge you to avoid is child and adolescent psychiatrists tend to avoid paroxetine or Paxil in adolescent patients, and there's a couple of reasons for this. One, paroxetine, although approved for adult depression, has an incredibly short half-life. And so this medicine often, because kids metabolize things faster, they end up in withdrawal from the paroxetine, which can be really uncomfortable and agitating, even if they miss the dose by a couple hours. And most of the adverse event data with SSRIs, like the suicidality, was really ultimately attributed to Paxil. So we just don't use this one. The rest, you can kind of make an informed judgment about. Paxil paroxetine was also linked to more risk of bad pregnancy outcomes and was actually rated category D because it had more adverse events in babies. And again, of our female population, we have a population at risk of getting pregnant on these medicines. There are some quick things to be aware of, Again, even though fluoxetine and escitalopram are the FDA approved ones, there certainly is data off-label, of course, for sertraline or citalopram to be used for depression. So you certainly could choose these, especially if another family member had really good success with it. If I have a family member that told me that their depression was super well treated with Zoloft and it had been the best thing that ever happened to me, and them, I might choose Zoloft for the child, even though that's not the FDA approved one, and that would be perfectly reasonable. So first line, we usually pick the Prozac or the Lexapro unless we have a reason not to, but any of them could be considered a switch. Just a quick word on Zoloft. It also has a little bit of a shorter half-life, so sometimes in young kids, it might need to be given twice a day to be better tolerated. The other ones can be given once a day. Here's a dosing table. Again, the fluoxetine and the escitalopram are highlighted because those are the FDA approved ones, but you can see here kind of our starting dose and the average dose that starts treating depression, and then the maximum dose. And if you compare this chart to what I gave you in the anxiety talk, it's very similar, but as a comparison, it's usually lower doses that the depression symptoms respond to. So you don't always have to push the dose like you do with anxiety. Now, if a child has severe anxiety alongside it, you may need to go up. You can start seeing pretty robust treatment even at these lower doses. That being said, don't be afraid to increase the dose if the patient's not responding and they're not having side effects. It would be better to maximize the medicine than to add extra things if you haven't optimized it yet. Things we watch for are stomach upset and restlessness, which are by far the biggest side effects. If a kid suddenly stops taking it, they may experience flu-like symptoms. If you go too fast with the dose, they may report anxiety. Fluoxetine tends to have a little higher rate of insomnia, so we usually tell people to take that one in the morning. One of the things that can also happen to just be aware of, if you've been on an SSRI every day for a really long time, some people just start complaining of feeling numb or that they have the blahs. This is actually a specific thing called amotivational syndrome, which happens from just having that serotonin receptors kind of a little bit dysregulated. It's hard sometimes to separate out from depression, although most people usually deny that they feel depressed. They just kind of don't feel anything, and they deny all the other symptoms. Like they're not having problems concentrating, they're not having suicidality. And this may actually prompt a need to change medications or taper it off and may not actually represent the depression itself. So just be aware of that. If you would convert to having bipolar disorder, SSRIs may agitate you and make things worse. And then some of these other ones we're going to talk about can have more cardiovascular effects and may have problems in overdose. SSRIs are pretty safe. So even in suicidality, if you take too much of your Prozac or your Lexapro, we don't usually see kids dying from that. If you would give a child one of these off-label medicines that we talk about, kids can die from taking too many of the other ones. Serotonin syndrome is when your serotonin levels get too high. It can cause rigidity, stiffness, fevers, flushing. If you're only using one medicine with serotonin capabilities, it's very rare that you would even have a problem. It tends to be seen more when there are multiple medications that might increase serotonin that someone's taking, or perhaps they have like a genetic problem processing the serotonin and the levels get elevated even at normal doses. So this is something to be aware of. Every medicine, it seems like I write, has a warning about suicidality, and SSRIs and any antidepressant, all medicines age 24 and younger have this warning. A lot of it is related to, I think, the fact that the serotonin can get increased so quickly. And sometimes kids feel restless or agitated or have more energy before their depression remits and may be more likely to report suicidal thoughts. This has been kind of a long-standing sort of thing, and it's sort of been debated in the literature. I do think it's real, but the rates are pretty low. And are probably less than 2%, if not less than 1%, depending on how you look at the timing data. So again, I think it's important you educate people about that with close monitoring, but ultimately treating the depression may often improve the suicidality, and that's something to be aware of. And this, of course, lends so many questions when parents read about that. There's a beautiful handout for parents at this parentsmedguide.org website that goes through all the pros and cons of choosing medicine for depression and talks kind of at length about the suicide risk. So it's a very nice read, and I think helps a lot of parents make a decision if they're struggling with that. These are some medicines that are off-label, SNRIs. Again, this would be venlafaxine and duloxetine or Cymbalta. Bupropion is Wellbutrin, mirtazapine is Remeron, and tricyclic antidepressants that might be helpful. Briefly, there's definitely data, again, from the Tortius study about venlafaxine being helpful, and it's probably the most commonly used non-SSRI that we use. Duloxetine got that FDA indication for anxiety, so we do tend to use it, but duloxetine does not have as robust depression data as the other medicines. Wellbutrin can be an augmenter and has some data, but again, not a ton of problems, and you have to be mindful of ruling out seizures or psychosis. But sometimes in kids with really low energy or concentration complaints where fatigue may be the most profound depressive symptoms, sometimes I add this medicine to the SSRI to boost it. And then mirtazapine, again, not super well studied for kids. It actually works through a different mechanism to increase norepinephrine and serotonin, but it can have a little bit of a sedating effect and can stimulate appetite and have some anti-nausea effects that might be helpful for kids that are really having problems sleeping or a lot of GI complaints as sort of an add-on as well. And then tricyclic antidepressants often are used for headaches and migraines and bedwetting. They actually don't have a ton of evidence in kids. In fact, there are 12 studies that show they didn't work in pediatric depression. So we don't really use a whole lot of these anymore unless there's another reason to choose them. And these, again, are really lethal. If kids overdose, they can really die. So you'll see these not used a whole lot, except as augmenters in really refractory conditions. And if you have a child who is doing well or they want to stop their medicine, it really is best to try to taper off of it. Again, 10 to 25% of the dose per week. Some people can stop the medicine without any problems, but lots of people don't feel good when they miss doses, and you can really help them tolerate it better by decreasing it. I will say that the venlafaxine seems to have the worst withdrawal, and some kids have a really hard time coming off of it, including these like horrible electric shock sensations they may feel in their bodies. And so that one in particular, you really want to decrease the dose slowly. A couple things that to just be aware of: there are some toolkits online for pediatricians to provide more guidance in primary care. And just to sum up quickly, you know, there are risks to any treatment, but we always have to weigh the pros and cons of treating depression with the risk of suicide, which is a medical emergency and kills a lot of children each year. So you don't want to miss this. You want to treat it effectively, and make sure that you realize that probably combination treatment with therapy and medicines may be the best way we help kids recover, protect against suicidality, and really, really boost their functioning. For mild depression, think therapy first. If it's more severe, probably the recommendation of the combined group will help. We usually pick an SSRI first, usually Prozac or fluoxetine, and if not effective, we switch to another SSRI or usually Effexor, a second-line treatment. And I've given y'all some online resources for families and kids. And of course, the last part is the PALS line, which is the cell phone that I carry to answer questions. And a lot of the questions I get are often about depression and suicidality and just how to tease things out and use the medicine. So please feel free to call. All right. What questions do you guys have?
Thank you so much, Dr. Sagar. That was awesome. And I'll certainly distribute your PowerPoint in that scale as well in the recap email. Any questions or comments for Dr. Swiger?
I wondered if Amanda or Colleen might add a little bit to the therapy part for kids with depression too, if we have some time, because I don't know if you have any. Oh, Colleen's pointing to you, Amanda.
Well, I mean, other than, you know, I think that you covered a lot of it. And I mean, other than specific tips and tricks, I mean, with kids especially, and for those of you who heard me talk about kids 5 and under, I always bring parents in to help them understand the techniques so that they can help them with them. A lot of the times kids are not going to be able to utilize the techniques on their own. So what I typically do is I teach the kids the techniques and then invite parents in and have the kids teach their parents. So that way they learn it as well. A lot of the times we do mood trackers, just understanding moods. And I think sometimes that can be overlooked, especially with little kids. Understanding what a low mood looks like, what a high mood looks like. Where were you? Who was around you? You can make it fun. You know, I know I do an activity where it's your defenses, right? Kids love to be superheroes. So what was the trigger and what is your shield, right? And we'll create a shield and we'll talk about that coping strategy and then what the outcome is. And, you know, kids can talk about it in that sense, like I didn't have my shield that day. And so then what happened and what did that look like? And how can we get that shield there, right? And starting to help them understand that. I always do the constellation of stars. I do that with a lot of different symptoms, like with anxiety, depression, family therapy, just the constellation. They're the big star, and who are the stars around you that are supports and healthy supports, and so really pulling that in. But yeah, those are just some of the, and mood trackers. I mean, we do mood trackers, feelings and emotion identifications.
I think Lauren, you hit some really good points that I always try to remember with kids and depression is one, that it can manifest in those physical symptoms. So the talking about the stomach aches and the headaches, keeping that in mind, that once you've ruled out your medical stuff, it really could be their way of describing the depression. And then the last one, big take home, is we know that it's most effective if it's therapy and meds together. But yeah, I think you guys all had really good points.
Thank you both so much. Those are all great points for sure. Any other comments or thoughts you'd like to share with the group? Or so I have any questions? All right. Well, thank you all so much for joining today. I do have a couple announcements for next time. So our session will be on November 18th from 12:30 to 1:30. So as you all know probably by now that the second sessions of each month are the 12:30 to 1:30 instead of 12 to 1. So thank you all so much for joining today. Thank you, Dr. Swiger, for that awesome didactic, and we'll see you guys next time.